On behalf of the American Heart Association, I would like to welcome you to today's webinar, The 4 F's of Anticoagulation Risk Assessments. My name is Anmol Dalwadi, and I'm a Quality Programs Manager for the American Heart Association. Today's webinar is possible with support from BMS Pfizer Alliance. I'd like to begin by going over a few items so you know how to participate in today's event. If you would like a copy of today's presentation, you can download a PDF from the handout section of your attendee control panel. If you experience technical difficulties, most user issues can be resolved by refreshing your browser. If that does not work, please review the system requirements or contact the GoToWebinar customer service team using the system requirements link found in your confirmation and reminder emails. At the conclusion of today's presentation, you will receive a link to access today's recording, a completion certificate, and an invitation to complete our feedback survey. We welcome you to submit text questions for our presenters at any time in the questions pane for the control panel. We will collect your questions and address them during the Q&A session at the end of today's presentation. It is my pleasure to introduce our speaker for today, Jeannie Luciano. Jeannie has been a Senior Manager for Quality for Stroke and AFib with the American Heart Association since May 2019. She has lectured locally and nationally on acute stroke management, stroke team, and stroke center development. Jeannie, the floor is yours.
Thank you, Anmol. And thank you all for joining the webinar during the course of your really busy day. We truly appreciate you and all that you do. I have no disclosures. So our objective today, this is a short introduction to the using of 4 F's in making an anticoagulation treatment decision for your patients. These represent areas to evaluate and are obviously supplemental to clinical tools such as the CHADS-2 and CHADS-2 VAS scores. So what are the 4 F's? So the 4 F's are frailty, falls, fear, and forgetfulness. And we're going to delve into each of these a little bit further. So frailty. So frailty is theoretically defined as a clinically recognizable state of increased vulnerability resulting from aging-associated decline in reserve and function across multiple physiological symptoms, such as the ability to cope with everyday or acute stressors is compromised. So when considering prevention of frailty, it is important to understand the risk factors that contribute to frailty and identify them early on. Observational studies found associations between frailty and a number of risk factors, such as low income, advanced age, chronic medical conditions, lack of education, and smoking. So as you can see, a lot of these are issues that we are looking at in when we look at social determinants of health. I want to tell you that there are multiple formal frailty assessment scales out there. I'm just going to go over one of them. These scales are for screening purposes only, and findings should prompt a more comprehensive assessment. So also keep in mind that you may find when I talk about age-related frailty, surely we would look at frailty primarily in the elderly population, but we all also know that you can see some pretty older 60-year-olds and some really young 90-year-olds. So keep that in mind when using these assessments. So this is the Frail scale. This is one of the scales that is pictured on this slide. This is not a self-assessment. This is not something you want to give the patient to fill out on their own. This is something that a care provider or a family member can help them in the assessment. So you want to ask them their age. You want to ask about fatigue. How much time during the past 4 weeks did you feel tired? A response of 1 or 2 are scored as a 1 and all others as a 0. Resistance. This is really looking at sort of their movement. By yourself and not using aids, do you have any difficulty walking up 10 steps without resting? Ambulation. By yourself and not using aids, do you have any difficulty walking a couple of blocks? such as several hundred yards. Illnesses. Did a doctor, and as a nurse practitioner, I always have to say a provider, ever tell you that you have had any illnesses? So there's a list of these illnesses, things like hypertension, diabetes, cancer, chronic lung disease, heart attack, congestive heart failure, angina, asthma, arthritis, stroke, and kidney disease. Loss of weight. So you want to ask them how much they weigh. And as you can see, a lot of these are questions that you are going to also be able to validate in doing your assessment of this patient. So 1 year ago, how much did you weigh? And then you want to look at a percent weight change as can be computed. So percent change greater than 5 is scored as a 1 and less than 5 as a 0. And then you come up with the total scale. A score of 0 represents robust health status, 1 to 2 pre-frailty, and 3 to 5 frail. Frailty has been significantly associated with malnutrition. If the participant screens as pre-frail or frail, ask them if they have been admitted to the hospital in the past 3 months. So as you can see, this is a rather short form, often something that is done in a outpatient clinical setting, and it can be done without any special tools as well. So falls, the second F. As you can see, there is a lot of crossover between the 4 Fs, and the second F is falls. Falls are a common result of frailty and are associated with death and significant morbidity, including prolonged hospitalizations, premature nursing home placement, social isolation, and fall-related anxiety syndrome. There are identified risk factors for falls. There can be intrinsic factors, including orthostatic changes, cognition, vision, spasticity, rigidity, weakness, sensory deficit, ataxia, and impulsivity. Or it can be extrinsic factors, including medications, environmental, and other factors. There are behaviors that include risk-taking, gait aid use, and other behaviors that contribute to fall risk. Just note that fall is a significant problem. 30 to 40% of community-dwelling older adults will experience a fall each year. This slide represents some fall assessment tools that don't require any fancy equipment and can be done in a clinical setting in a relatively short amount of time. So there's the 5 times sit to stand, or the 5X STS test. This test assesses strengths. You have the patient, you have the patient sit in an armless chair with a firm seat. Ask him or her to stand up and sit down as many times as possible, and record the time required to complete the 5 repetitions. The single leg stance, the SLS, this test assesses balance. Have the patient stand on one leg with arms crossed. Now, oftentimes, patients who are at all impaired have difficulty doing this. The time, how long the patient can remain in the position without touching the suspended foot to the ground, moving the hands away from the chest, or displacing the weight and weight-bearing foot. The timed up and go, or the TUG, is probably the most common one done, and this is often done in clinical trials in assessing patients for fall assessments. This test assesses gait. Have the patient start in a seated position, rise to a stand, walk 3 meters, and return to a seated position in a chair, and record the time required to complete the exercise. There's the rule of tens can determine which patients should be considered for further evaluation. Patients who take more than 10 seconds to do the 5 times STS and TUG test, and those who can balance for less than 10 seconds during the SLS probably require some further evaluation and assessment. So what can we do when we identify an issue with falls? So patient and support person education is really important. Fall prevention is essential for people at risk. even some simple issues around education, like don't walk in socks. I wish I had $1 for every patient who told me they got up out of bed, they had socks on, and they slid. So little things like that can help a patient prevent falls. Physical therapy and occupational therapy evaluations are kind of the gold standard for intervention when you identify a patient at risk for falls. They can help identify the need for assisted devices such as canes or walkers, and even more importantly, demonstrate proper use of these tools for the patients. A home environment assessment is really key. Sometimes a skilled eye in the home can identify potential opportunities to eliminate or modify risk. Home modifications, such as installing railings along stairs and grab bars in the shower, things like elevated toilet seats can help a patient prevent falls. Oftentimes, particularly with the grab bars, we have a lot of people, most ERs see a fair amount of people who have a fall because they've grabbed onto something that is not intended to have weight pulled against it, and they fall because they pull something out of the wall. So fear. So fear is really, and I put on here providers and patients. Fear of bleeding is a widely acknowledged reason for why physicians do not prescribe anticoagulant therapy. Some patients may, all anticoagulant therapies necessarily involve some degree of bleeding risk. Anticoagulated related bleeding risk may be lowered by consistent use of evidence-based stratification schemes designed to help physicians identify patients who require anticoagulation to reduce the risk of stroke, predict the risk of bleeding during anticoagulant therapy, and take preventative measures accordingly. With providers, it's really important that they provide research-based care. So we want them to make the decision. Oftentimes, as a provider, we get led by the outcome of our last patient. We'll have a bad experience and decide to treat a patient differently. I had a very skilled elderly physician once tell me when we had a poor outcome is stay research-based in your care. You can't be guided. You can't guide your, you can't treat your patients based upon the outcome of your last patient. So stay research-based in your care. Some patients, I'm sorry. Oh, medication adherence. I'm having trouble with advancing here. Medication adherence may be fostered by the use of the fixed dose anticoagulants rather than warfarin, which requires dose adjustment and monitoring to maintain anticoagulant effect within a narrow therapeutic. Some patients may have hearing or cognitive impairment, which can even be more challenging. You think about adjusting warfarin dose and making a call and saying to them, we got your INR. We're going to have you take 5 milligrams of warfarin on Monday, Wednesday, and Friday, and 7.5 milligrams on Tuesday, Thursday, and Saturday. What I have found in practice is that it's also helpful in patients who have email to say to call them and give them this direction and say, I'm going to email you these directions as well, so that they can visually see them and refer back to them if they have any questions. Education really plays a key role in minimizing patient susceptibility, helping patients understand the importance of lifelong anticoagulation and the need for consistent lifestyle measures, and raising awareness of signs and symptoms of adverse events, including bleeding. A lot of our patients develop fears based upon things that they see on TV, on the internet, or conversation with friends. We hear them talk about, oh, anticoagulants, that's rat poison, that kind of fear. You want to be able to address these with facts. And I always called their internet searches, their little portfolios they would bring in with a variety of information that we'd have to review. Forgetfulness. So compliance with anticoagulation is really essential to effective treatment. Many of our patients are on polypharmacy, and when I say, it's not unusual to see a patient who has complex medical cares on anywhere between 10 to 15 to even 20 different medications. So it can be quite confusing for them. You will find also that elderly patients also often associate their medication with pill colors. This isn't reliable. My father used to get his pills in the mail, and he would say, okay, so, in the morning I have to take one yellow, one blue. But then, of course, they would change dose and the colors would change. So that was never, this just isn't reliable to look at the colors anymore. Technology has really given us some good options for medication tracking. There are medication pill containers that will alarm when it is time to take a medication. The key is to make sure that they are filled properly. Some people enlist the help of a visiting nurse or an aide to help with that process. There's a variety of apps out there that patients can use to help, number one, identify their pills, but also to alarm them that it's time to take a medication. Something that is relatively new is the pill packs, where they can get them pre-packaged through a variety of routes. And the only trouble with this is when they have a change in medication and require adjustment accordingly. So for as far as forgetfulness, we want to look at the overall prescriptions with a critical eye. Make sure that there's a good sense in the medication regimen, and if possible, use some combination drugs. We want to use the medication boxes and the boxes and prepackaged medications, the alarms. And routine is really important, trying to synchronize medication timing with meals. So if you can say to somebody, at breakfast, you're going to have this, at lunch, you're going to have this, at bedtime, you're going to have this medication. Often that kind of routine helps to ensure compliance. You want to try to enlist a partner, somebody who's going to monitor that they're taking their medications. I had a colleague who did some research around this, and what she found was that men were most compliant when they had a wife who was tracking their medications. You also have some opportunities for some home health interventions. You can have a home nurse go out and check for medication compliance. Oftentimes, as a provider, we would get notifications from pharmacy about patients who were not appropriately filling their medications or not taking their medications. So just some parting thought. No decision is really made in isolation. This is really multifactorial risk versus benefit decision. And this is something you want to have a conversation with your patient and with their significant other around why the decision is made to use this medication. There's a lot of dangerous medications we use, and we want to make sure that we have good rationale for it and have a conversation around this shared decision making. This is not a once and done conversation. Sometimes factors worsen, sometimes they improve. So it's worth it to go back and to reassess these patients and see if they have had a change in status that makes you rethink the decision. You also want to ask the difficult questions. When we go into a hospital or into a medical visit, oftentimes there'll be questions around everything, do you feel safe in your home? Do you have a firearm? Do you, those kind of questions, all important issues. But I always say that the most important question you can ask a patient is, do you have a plan to get your medication? I saw a cartoon once that said, do you have something, talking to a pharmacist, do you have anything for anxiety? I'm trying to understand my Medicare Part D. And this is really things are very confusing for our patients. Don't assume, even if they do have medication coverage, that they have the financial resources to get those medications. Sometimes they're paying for half of them. And if you have a patient who is making a decision on whether they're going to eat or pay their electric bill or get their medications, you're going to have compliance issues. So ask the difficult questions about medication, whether they can afford their medications. Beware of transitions. You would think that, being in a hospital, being in an ICU and transferring to a floor or transferring from an emergency department to a floor is the most dangerous transition. I would challenge that and say that the most dangerous transition is when they're going home, because, they're in the hospital. There's going to be, if somebody misses something, there's going to be 20 other people assessing that. So we want to make sure that they are going home with very clear-cut information, whether they're leaving a hospital or they're leaving your office. Also be aware of the transitions when there is stoppage of anticoagulation. Prior to a procedure that requires stopping anticoagulation, oftentimes a patient will not clear that they should resume their medications. I've seen patients who have presented in clinic or even presented acutely who stopped their medication for a colonoscopy and then never resumed, so were untreated. Another F may be family and friends. I guess the F around the difficult questions and being able to afford their meds would be financial, but the other F may be family or friends. And if you can elicit help from a family member or a friend to help to monitor things at home, is really key. We have to keep in mind, and I look forward to the time when we can have a conversation and not say the word COVID, but we have to keep in mind that particularly our elderly population may be more isolated in the past year and a half than they have been previously, may not have some of the initial resources that they normally would have, and also may be afraid to have outside resources in their home. So this is a particular concern, I think, at the point in time when we've been in the realm of COVID. These are some resources for you if you would like to look at any of the additional screening tools that are out there. And I would like to thank you for your time and attention, and really for your commitment to optimizing the care of your patients with atrial fibrillation. I am happy to take any questions.
Great, thank you, Jeannie. My name is Liz Olson. I'll moderate our questions for today. And just as a reminder, you can submit your questions at any time through the questions section of the webinar portal. While we're waiting for additional questions to come in, Jeannie, I'm wondering if you could talk about how if my hospital wants to implement some of these formal screening tools or work on our processes, from your perspective, what would be a good way to start looking at this for quality improvement?
Thanks, Liz. I think as a team, it's important to think about tools that are going to work for your group. Not everything's going to work for everybody, and I think number one would be to review the different tools out there. Time is a true factor, whether you're doing this in an inpatient setting or you're doing it in an outpatient setting. And also think about your population. Do you have a population who has language barriers, who have, you may have a certain population that has additional financial barriers that other people don't have. So think about what your population is, have your team look at the scales together to see what would work best in your setting, I think is my best recommendation.
Okay, great, thank you. As far as judging forgetfulness, is there something that can be done on admission or to get some background from the family to assess whether how much additional help a patient needs as they're getting assessed?
Sure. There's actually one of the scales that we use in you're essentially assessing cognition is the MOCA scale, the Montreal Cognitive Assessment Scale, and that can give you some idea about their processing of information and retention of information. A lot of it, you sometimes get more out of a conversation with the patient, even just within the context of a admission interview, than you'd even do from the scales. You'd be able to get a good sense of forgetfulness and talk to them about compliance. And some patients are pretty self-aware of their forgetfulness, and then there's others who are trying to hide it or try to cover it up. But I think it's just a general conversation, as well as possibly using things like the Montreal Cognitive Assessment Scale. That takes a little bit longer than some of the scales in order to complete.
So another question we received for concerns about affording medications, and what's the best way to have that conversation with the patient and their family, and address any cost concerns for their medication?
That's a tough conversation to have sometimes, because people can be quite proud. They can try to think that they can figure it out on their own. I think the number one thing is to have that conversation and to give them a resource if they go out and to get their medications filled and find out that it's going to cost them more than they were aware of. Oftentimes the social work, or especially with any of the anticoagulants, because you need a little bit of pre-planning, social work or a clinical resource manager will talk to the patient and check for their insurance approval prior to leaving. Many of the pharmaceutical companies have coupon plans where you can get low cost or low copay medications. So I think trying to have that honest conversation with the patient is really a key issue.
Thanks. You mentioned earlier in your presentation something I think that we hear commonly is the misconception or the perception about anticoagulants, certain anticoagulants being rat poison and some other just really challenging perceptions to prescribing certain types of medication. For something like that, are there any best practices that you would recommend in how to address a concern like that?
Yeah, I mean, quite frankly, I think warfarin is a component of some of the older rat poisonings. So if they go to what I always refer to as Dr. Google and look it up, they're going to see that. I think, giving them written information and reviewing that information about the medications before they go home or before they leave your clinic is really valuable. People, they also, not only do they hear that kind of information, but they also are watching commercials where, if you have a bleed related to use of, whatever anticoagulant, call our law firm. So they're really bombarded with information. So I think my one real plan around that is to really counteract the information that they're bombarded with facts and with scripts about the information. And most of us, when we do discharge, are able to give the patients a more easily understandable patient medication form than they get when they go to the pharmacies. So I would try to just combat it with facts.
Well, thank you, Jeannie. That's all the questions that I have, so I'll turn it over to Anmal. Thank you.
Thank you, Jeannie, for leading today's webinar, and thank you for your participation in today's event. After today's webinar, you will receive a follow-up email with the survey on the presentation, and we would appreciate if you'd complete that and provide your feedback. In that email, you will also receive a link to view a recording of today's presentation and a certificate of completion. On behalf of the American Heart Association, thank you for joining us and have a great day. This concludes today's presentation.